In this lecture, we're going to cover hypersensitivity and autoimmune diseases. We're going to first kick off by walking through the 4 different types, but then we'll focus specifically on type 1 and type 2. Pay attention to this image in the lower left right here. This is an example of hives and a nice indicator of a type 1 type of hypersensitivity. So we'll take a look at that a little bit more in detail here in a moment. First, let's describe what is hypersensitivity. So hypersensitivity is truly an immune response. It is an immune response that is supposed to be beneficial, and then you have the added problem or the added deleterious response of tissue damage, and that comes as a result of hypersensitivity. So what's going on is the immune system is being triggered, and it's more aggressively being triggered than what it normally should be. And so this is what you see in that example that we just looked at with that individual with hives. The individual is first sensitized to an allergen, and then what happens is the response is now triggered and inappropriately maintained, and it doesn't subside. Once it gets going, it's difficult for it to control, it's difficult to stop. The stimulus usually does not go away or disappear. And so hypersensitivity is a classic example in the immune system of a positive feedback loop. 4 different types of hypersensitivity that we're going to cover. This is a nice summary slide. Type 1 is an IgE-mediated response. As an IgE-mediated response, this antibody, as you recall, is in the lowest concentration of all the immunoglobulins in the circulation. It functions to mediate allergic reactions and to respond to parasite infections. Now, there is a group of patients in the population who are considered atopic. And atopic individuals are those that produce excessive levels of IgE. And these IgE levels are typically higher than what normal individuals would produce. And so they're a lot more susceptible to an allergic reaction because of that. Type 2 is what we call a tissue-mediated or specific response. It is antibody-mediated. So in type 2, we've got the IgG and the IgM family that are primarily involved. And great examples of type 2 hypersensitivities are those that involve blood transfusions. So if you look at the erythrocyte membrane protein that's being expressed, we either have a type A, a type B, or a type AB antigen that's being expressed. So individuals either show A, they show B, or they show both, or in some cases they show neither, and they're type O, or their absence of these red blood cell or these erythrocyte membrane proteins. And those can be antigens towards one another. In addition to that, we have this rhesus factor, or this Rh factor. And that Rh factor is that positive or negative that's after your blood type. So if you're A negative, or let's use A positive as our example, then your erythrocytes express a antigen, A-type antigen on the surface, and they express the rhesus factor. And it's called the rhesus factor because it was originally discovered in rhesus monkeys. Okay, so antibodies are generated towards a specific tissue or protein group that's being found on these different membrane surfaces. Type 3, this is an antigen-antibody complex. Okay, so in a type 3, a complex is going to form, and that complex is going to go and get lodged somewhere, and we'll look at that more specifically. So the main difference between type 2 and type 3 is both involve the production of antibody, but in type 2 the antibody binds to the tissue, and in type 3 the antibody finds the antigen, and that forms a complex, and that complex gets stuck somewhere. Okay, a lot of times it's going to get stuck in different tissues that have filtering-like capabilities, okay, because it's going to catch that complex. Some examples of type 3 are autoimmune diseases that include diseases like systemic lupus, erythematosus, or SLE, and rheumatoid arthritis. Those are two examples of type 3 hypersensitivities. Type 4 is classically referred to as T-cell mediated. So it's different than the previous three types that we've looked at. Okay, the previous three types are all involving antibodies. Type 1 is IgE. Type 2 and 3 both involve antibodies. And now with type 4, antibodies or B cells are not involved. This involves T cells. So these T cells primarily are cytotoxic CD8 positive T cells that are involved. So we call this a delayed hypersensitivity, and the reason for that is it takes a little bit more time for this to take place. Examples here include type 1 diabetes, as well as transplant rejection when you're doing a donor kidney or a donor organ from one patient to another. So let's now walk through type 1 and type 2 in more detail, and then in part 2 of this lecture we will cover 3 and 4. So type 1, we said, was an IgE-mediated response. It responds to allergens. There's a sensitization process that takes place, and this is classically allergies or allergic reactions. Now, these allergic reactions would fall under the category of, if you're allergic to pollen or pet dander, or you're allergic to olive trees or certain pollens at certain times of the year, but also food allergies. Food allergies would fall under this category as well. In addition to food allergies, drug allergies, like allergies to penicillin or certain medications. So you go see the doctor and they always ask, are you allergic to any medications? This would be because of their fear or their concern around type 1 hypersensitivity. So what happens here is you proceed to what we call a B cell and a CD4 or a helper T cell activation. And the CD4 subtype that's used here is called CD4-2. This is a subset of helper T cells, and they're specifically involved in this allergic type of response. And the goal here is to sensitize mast cells. Mast cells are the cells that are responsible for releasing all sorts of chemical mediators to stimulate that allergic reaction, including things like histamine. Okay. So if you look at this picture of what's going on, you can appreciate that here we've got our allergen, okay, that's being exposed to our B cell, and here is our T helper cell, subset 2, that's helping to facilitate this process. We get the production of IgE-mediated antibodies, and that binds to mast cells. The mast cells become sensitized, and under the second exposure, they respond more aggressively, and we'll look at that here in a moment. And what they ultimately do are release these chemical mediators. And some of them are in this category of being vasoactive. What that means is they're going to have activity on the blood vessels, and things like histamine. And then other ones are cytokines that are going to respond to the late phase after repeat exposure. In this slide, we're now looking at the second exposure after the initial exposure in a type 1 hypersensitivity. So what happens here? What happens on the second exposure? Well, on the second exposure, we get the allergen that actually binds to 2 IgEs. Okay, 2 IgE antibodies are going to find that allergen. So now we already have this heightened response. We get two main things that take place. We get what we call degranulation, and then we get de novo synthesis. Degranulation is basically dumping of the contents of these vesicles. So these intracellular vesicles are going to fuse, and they're going to spit out their contents, and these granular contents include things like histamine, which has activities to the blood vessel, proteases, chemotactic factors, okay? And then secondarily, we're going to get this de novo synthesis. This word de novo synthesis means manufacturing from scratch, okay? And that manufacturing from scratch is of the prostaglandin and the leukotriene family. So if you think back to the previous lecture when we looked at inflammation and the role that arachidonic acid is a precursor, which is generated from the lipid membrane, but it has to be manufactured. So we now turn on the synthesis of arachidonic acid by converting some of the phospholipid bilayer into the arachidonic acid intermediate, and then subsequently to prostaglandin and leukotrienes, which have the late phase activities. These late phase activities are things like recruiting leukocytes, epithelial damage, and even bronchospasm. In contrast, the immediate response that comes from these granular contents are things like vasodilation, vascular leakage, and smooth muscle cell spasm. Let's look at the clinical manifestations. So when a patient is having an allergic reaction, okay, and we all have all had them. You can think back to, maybe today or yesterday and think about what are the issues associated with allergies. Well, a couple of clinical symptoms, most of these are due to the vasoactive amines, or these early phase responders like histamine and such. And the symptoms are going to be the following. We get conditions known as itching, right? We get pruritus. We get bronchospasm, or a spasm of the bronchial airways. We get a laryngospasm, which is a spasm of the larynx. We can have tissue edema, which is fluid collecting in the tissue. The tissues get swollen. The eyes get swollen, the nose gets swollen. Or if you have sort of a hive-like response, hives, the tissue itself, that epithelial tissue, swells. Conjunctivitis is a redness of the conjunctive linings, like the eyes, the white of the eyes. Rhinitis is a runny nose, essentially. We get hypotension, so we'll actually lower our blood pressure because we have leaky vasculature. So a lot of that fluid is leaving the bloodstream, and so that's helping, or that's contributing, not in a helpful way, but that's contributing to lowering blood pressure. And then we can even see things like gastrointestinal cramps. Now, cell infiltration that comes as a result of these vascular symptoms can cause the tissue damage. And specifically, you'll see a lot of mucus overproduction or hypersecretion, and this is a result of one of the cytokines known as interleukin-13. Interleukin-13 comes from mast cells, and as they degranulate, the interleukin-13 is one of the things that they spit out. Okay, let's look at some examples, clinical examples of type 1. So, food allergies, I mentioned. Anaphylaxis, right? This is a abnormal reaction to a stimulus, like an antigen. Anaphylactic shock can happen as a result of a bee sting or a wasp sting. Anaphylactic shock can happen in some patients that have a severe shellfish allergy. So anaphylaxis, food allergies, environmental allergies like pollen and stuff like that, a wasp or a bee sting, or even drugs like penicillin allergies. So if you take a peek at these pictures, this upper image is illustrating a normal larynx. Okay, this is looking down the back of the throat, and you are appreciating a normal laryngeal opening. Now, the lower image is an example of an anaphylactic reaction to penicillin. Okay, this patient actually didn't make it, and the airway is significantly compromised as a result of a type 1 hypersensitivity reaction due to preformed IgE-mediated antibodies, or IgE antibodies that are on mast cells, and they responded really, really quickly to that subsequent reaction. Okay, shifting gears to type 2, and that's going to wrap us up for part 1 of this lecture. Type 2 is a little different. It is called tissue specific, and these antibodies are going to bind to an antigen that's found in or on a cell. So the tissue-specific hypersensitivity is going to circulate around the body, and it's going to find that antigen, and it's usually an antigen that's contained inside of a cell or on the surface. And again, we said some examples here were blood transfusion rejections. When you donate blood, you have to pay close attention to, what is your blood type, or when you receive blood, you have to pay attention to what type of blood you're receiving, not just the A, B, or O designation, but also that rhesus factor. They form antibody-antigen complexes, but they form them in the tissue. Okay, so if you can appreciate this image, a lot of times what we're going to see happen is we're going to see a result take place due to antibody production that happens as exposed to certain types of bacteria. So in this particular case that we're looking at with the type 2, we can actually see and appreciate that this patient who had a streptococcal infection or strep throat developed antibodies that were anti-strep antibodies. This is a lymph node that we're looking at. These anti-strep antibodies were starting to circulate around in the body, and they actually found locations in the body that they bound to where there may be some residual strep bacteria. And if that location happens to be in the pericardial tissue, then you result in what we call a fibrinous pericarditis. If it's in the cardiac myocardium itself, it results in a condition known as an Ashkoff body that we'll talk about in a second. Or it could show up in some of the vegetations inside of the heart itself. And this would be an example of what we call acute rheumatic heart disease post-streptococcal infection. So type 2, further discussion of type 2, a result of rheumatic infection or rheumatic fever is classic type 2. This was first described many years ago, and they were originally called an Ashkoff-Geipel body because of Ludwig Ashkoff and Paul Geibel. But more recently, we've kind of dropped the Geibel designation, and we call them Ashkoff bodies. These are nodules that are found in the heart. This is cardiac histology that you're looking at here. And these were individuals that had rheumatic fever, okay? And the rheumatic fever would show up as a result of a post-streptococcal infection. And another term for this was scarlet fever. And these antibodies would characteristically bind into areas, connective tissue areas of the heart, and stimulate inflammation. And the inflammatory response that ensued would create this Ashkoff body, which is this lesion right here. This is sort of normal myocardium here, normal myocardium on the right. And this lesion right in the middle is scar tissue, otherwise known as Ashkoff body, as a result of rheumatic fever and inflammation of that connective tissue because of that type 2 hypersensitivity. So what are the possible outcomes of type 2 hypersensitivity? Well, first off, we can stimulate the process of phagocytosis. Okay, phagocytosis, these first we'll start with antibody opsonization, which is the process by which the pathogen is marked for ingestion and destruction by a phagocyte. So antibody opsonization is what happens as a signal to say, hey, let's phagocytose this. Secondly, inflammation. And you saw inflammation classically in the type 2 Ashkoff body presence. So this inflammatory process can either use or facilitate with complement damage or neutrophil damage. So that is the result of what happens in a type 2. We either see phagocytosis or we see inflammation. Let's now turn our attention to a clinical example, and this will wrap up our part 1 of this 2-part lecture. In this clinical example of type 2, we're going to look at 2 different diseases. Okay, the first one is let's describe the first one as Graves' disease. Okay, so Graves' disease is this mechanism shown on the lower left, and Graves' disease is a type of thyrotoxicosis or hyperthyroidism. Okay, this is brought on by increase or overstimulation of the thyroid gland by thyroid stimulating hormone mimicking antibodies, or TSH mimicking autoantibodies. Okay. So what happens is you can appreciate in this picture that these antibodies have specificity to the TSH receptor on thyroid tissue, and they actually stimulate the activity of that thyroid cell without any thyroid hormone, without any TSH hormone available. So they are stimulating an inappropriate response because of autoantibodies developed towards those TSH receptors. Okay. In these patients, the symptoms include an increase in basal metabolic rate, increase in heart rate, weight loss because their metabolism is elevated. It's difficult for these patients to sleep at night. And we will talk later in the semester about thyroid diseases, and we'll come back to Graves' disease. Okay, the second example that I want to highlight is myasthenia gravis. Myasthenia gravis comes from the Greek word that means literally muscle in Greek and weakness, gravis, in Latin. So it's a combo of a Greek and Latin term meaning muscle weakness. So myasthenia is muscle in the Greek, and weakness, the Latin derivative, gravis. So we have severe muscle weakness here. And this is characterized in this picture by this lower right image. And so what's happening here is we get antibodies that actually are manufactured towards the acetylcholine receptor. And these antibodies bind and they inhibit the ability for acetylcholine to bind on the postsynaptic motor end plate. So if this is the nerve up here and this is the muscle, and we remember back from anatomy physiology that the acetylcholine is being released, SNAP25 helps with the fusion of this vesicle to dump out acetylcholine. But if you have these antibodies that have bound up the receptors on the postsynaptic cleft, those acetylcholine molecules will have a difficult time finding the receptor that's being blocked, and therefore you do not get muscle contraction. And that's the condition of myasthenia gravis. So that wraps up part 1 of 2 parts of hypersensitivity.